On the 27th of January, we were called to a 15-month-old male with burns to the left hand. Upon arrival, I asked his mother how the burn was obtained and was told that he placed his hand in a bowl of hot milk. The patient was extremely distressed, and the initial assessment of his hand showed partial thickness burns to the middle and index fingers with the skin lifted. The burn was treated with a moist combine dressing, and we also provided 15 micrograms of fentanyl IN and 180 milligrams of paracetamol orally. The treatment was effective as the patient responded well and ceased crying en route. This case made me question if we carried out the best overall care for the patient. As the pre-hospital care for burns is only limited, and considering the distress of the patient, we chose to focus on pain and calming the patient. Since on road, I have encountered many pediatric patients, but never one presenting like this. In the clinical environment, I have not experienced children with this amount of distress. However, I have had many years of dealing with upset children within my family, which does assist me with these sorts of cases. When discussing the treatment options with my mentor, I suggested using a burn aid dressing to treat the burn, as learned at university. My mentor, however, stated that although this is the correct treatment option, he did not want to use this technique, as the burn had resulted in raw exposed skin, and for this patient he did not feel comfortable introducing a chemical that could cause complications. The main focus of this case was pain management, which involved treating the burn, providing pain relief and psychological support. Although burn aid dressings are recommended by the QAS CPM 2015 to small surface area burns, in this case we did not use them. We chose not to use this dressing as it can cause hypothermia in patients, and due to its very effective cooling of burns, as outlined by the Ambulance Victoria Burn Aid and Burns Management 2010. It was a cold day, and we were treating such a young patient, therefore we did not feel comfortable reducing his body temperature. The Burn Aid website 2015 states that the gel in the burn aid dressings can cause irritation of the skin in certain patients. As the patient was greatly distressed and had raw exposed skin, we did not feel comfortable potentially exposing him to further irritation. Our choice of a moist dressing in the treatment of the burn was the best for the patient because it did not cause him any further issues and relieved some of the pain. For this patient, we used fentanyl-delivered IN to relieve his pain, as it is fast-acting and its delivery route will not cause any further distress. Wilkie and Broad, in the American Academy of Pediatrics Journal 2010, suggests that IN is the most ideal way to administer drugs to pediatric patients, as it has a similar onset time as if administered IV, which is verified by the QAS DTP 2015, but does not cause as much distress. Dunn et al. 2009 in the Pre-Hospital Emergency Care outlines that their research has conclusively proven that fentanyl is a preferred drug as it has minimal side effects, opposed to morphine that can have serious effects, especially on the central nervous system, thus proving that our choice of pain relief was optimal for this particular patient. Psychological support was key in the management of this patient because he was so distressed. We hoped to minimize the distress by having his mother nurse him in the ambulance. Research by Cole et al. 2008 in the Child Care, Health and Development Journal states that there is evidence that pediatric patients who have a family member or parent present are less distressed. Harris et al. 2010 outlines their evidence that medical professionals prefer having a family member present during medical procedures, as it has a calming effect on the patient, thus making the process easier, which we also found in our case. The research I have conducted along with my experience on road has taught me a lot about pediatric burns treatment. In this case, my mentor chose not to follow the clinical guidelines in terms of burn treatment. In the QAS CPM 2015, it is outlined that the clinical guidelines should be used in conjunction with paramedics' clinical judgment based on their scope of practice and experience to best determine the ideal treatment for the patient. Prior to this case, I believe no matter what, you must follow the clinical guidelines provided by the QAS. However, I now understand that sometimes the clinical guidelines might not be ideal for certain patients, and therefore, in the future, I will use my experience, clinical knowledge, and the clinical guidelines to judge the best approach for the patient. Previously, although I considered IN to cause less distress, I was unaware that IN fentanyl is just as effective as IV, which was outlined by Dunn et al. 2009, as I assumed that IV would be the most effective in all cases. In the future, I will have the ability to make sound decisions that will benefit the patient in terms of drug effectiveness and lack of distress. Finally, the research by Harris et al. 2010 provides evidence that is highly effective to provide psychological support to pediatric patients, as it reduces stress and makes it easier to treat the injury, which I never considered before. From this research and viewing the effectiveness on road, I feel as though in the future I would definitely encourage a family member to accompany the child to hospital. providing the patient with the best environment to reduce distress in the pre-hospital setting. From this case, I've learned a lot about paediatric treatment of pain, and my future treatment decisions will be informed by my research and this experience.